All right. So I would like to start this meeting on behalf of the Brain Health Center of the Rockies. My name is Augusto Miravalle. I'm a neurologist here in Fort Collins, Colorado. And today we have a wonderful panel of experts in the field of dementias. And we have Dr. Brett Flynn, who is going to moderate this conversation. Brett is an associate professor at CSU. And Brett specializes in understanding and investigating the role of exercise in overall brain function and brain health. Most of his lab specializes in multiple sclerosis, but also he has worked in the field of Parkinson's disease and early MCI. We have also Peter Pressman. Peter is an assistant professor of neurology at the University of Colorado in Anschutz. And Peter specializes in dementias and related disorder. And he's going to be part of the panel as well. And last but not least, we have Danielle Hubbard. Danielle is the Director for Health Systems at the Alzheimer's Association and related dementias. Danielle is based in Denver, and her territory includes multiple regions in the Rocky Mountain area that probably if I try to spell them out, I'm going to have them wrong. So she's going to introduce herself when her time comes. And for today, what we decided to do is review in the best possible and most accurate way recent data on not only management of Alzheimer's, but also related dementias. And we'll have a small section to talk about a frontotemporal dementia. And what we decided to do today is go over published data on Alzheimer's disease management, particularly on one medication that was recently approved by the FDA called Aducanumab, and present that in the most unbiased and accurate way to our audience. Understanding that this is highly controversial and there's been a lot of information out there. So we're hoping that but at the end of today's presentation, the audience will have a much clearer way to understand this information. And this is part of what we call the Research Club. And the Research Club is a series of talks that we bring through the nonprofit, the Brain Health Center of the Rockies, that we invite experts in an area and we review recent articles and we kind of dissect them in a way that anyone can understand them and hopefully apply that knowledge into your life or the life of your loved ones. So without any further ado, I will initiate this talk and I will invite Dr. Brett Flynn to moderate this session.
Thank you, Dr. Miravalle. Thanks everyone for joining us on a warm kind of summer Monday evening still. As you can see here on the screen, we have the sort of broad topics or questions that we're going to make our way through and address. As Dr. Miravalle or Dr. Pressman are talking, I want to encourage everybody, by all means, please feel free to type questions in. So there is, if you kind of hover over your Zoom screen and look down towards the bottom, there is a Q&A box that you can bring up. And within there, you can type in questions, and I'll be collecting and sort of putting together all of those questions so that in between each of these topics or questions that you currently see on the screen, we can jump in and ask Danielle or Dr. Miravalle or Dr. Pressman to give us their thoughts on some of the specific questions that you may have or some of the specific questions that come up as you're listening to them present. And I'll then jump in the middle and ask away. So by all means, feel free to type at any time it hits you and you think of it, jump in there and put your questions in and we'll be ready to go. I think to get us started, if we're going to discuss dementia, types of dementias, treatments and efficacies of different treatments, the first thing we really need to do is define what we're talking about. So Dr. Miravalle is going to get us started by telling us what do we mean when we say dementia, and how do we go about accurately diagnosing those who we think may have dementia?
Thank you, Brett. And just to go into some definitions, so perhaps the most accurate definition of dementia, or at least pragmatic, that we can all understand, is a loss of previously attained abilities in daily life, impacting functional independence. And often I try to gather that from history in patients who themselves or their loved ones identify any concerns on any cognitive domain. And one of the questions that perhaps is most meaningful is, well, how much of this deficit is affecting your independence to function in activities of daily living? And that perhaps is one of the most practical ways to define true onset of dementia, when that the accumulation of these deficits in one or multiple domains of cognition, whether it's memory, attention, multitasking, executive functioning, processing speed. I mean, our brain does a lot of wonderful things, right? And most of those things are related to some cortical activity in the brain. And when those areas or domains get affected, we may or may not see any functional abilities that gets affected. So that's one key component of dementia. There is a term that we often use called mild cognitive impairment. And I see that as a step prior to dementia. Though not all patients with MCI or mild cognitive impairment may evolve into dementia, we often see that there is often a first step into what later would constitute dementia. In those cases, individuals with MCI will still retain the ability to function independently despite having concerns or deficits in one or more domains of cognition. And I mentioned now cognition multiple times, so might as well let's define it, which is the mental processes for gaining knowledge, thinking skills that includes memory, word finding, attention, concentration, processing, speed, and problem solving. So pretty much most, if not all, of the functions that our wonderful brain can do for us. And I always like to throw this term anytime we talk about neurodegeneration or dementias, because we have to remind ourselves that the brain is extremely plastic. That means that it changes and adapts, and it has the ability to change not only the way it's functioned, but also in response to the environment. So we should not see these terms as fixed steps or milestones into some sort of natural history. Often patients fluctuate between these stages, particularly early on. So it's possible that, you know, one time we assess a patient and has a complete loss of dependence, and the next day there are some improvements, or vice versa. So this plasticity is something that we often see. And it's also another way to look at plasticity is with some degree of hope that if we can stop whatever process is leading to these pathological states, perhaps the brain may improve its function depending on the circumstances. So as Brett mentioned, there are many types of dementias, and by far we always see that Alzheimer's is the most common when you look at all age groups. However, for example, in individuals that are younger than 60 years of age and they do have dementia, for example, frontotemporal dementia is the most common one. So it truly depends on the age group. We also see that individuals with certain cardiovascular risk factors, hypertension, strokes, and smokers, they have another type of dementia that is what we call the vascular dementia, that instead of affecting the cortex or the outer layers of the brain, has more of an involvement in the white matter or the subcortical compartments of the brain. And of course, we have the mixed types of dementia. Anytime in medicine we try to define boundaries between diseases, we always have the mixed syndromes, which has a little bit of everything, right? And that becomes more of a challenging puzzle to understand, okay, what is the typical presentation of a syndrome and what aspects of these syndromes patients have. And often we see that individuals may present with some Parkinsonian features or from Parkinson's disease, and perhaps they have, you know, markers in their blood or spinal fluid that are more suggestive of Alzheimer's type. And we start seeing these mixed syndromes. And then there is another one that perhaps is not common, but is very characteristics when we see that in the clinic, which is a so-called dementia with Lewy bodies, that in that case, patients do present with some Parkinsonian features, hallucinations, sleep disorders, and so on and so forth. So as I mentioned before, this is a continuum of disorders that could happen to an individual, anywhere from the so-called normal aging, which we all go through. And that's just simply try to explain that our brain, like any organ, may sustain some effects of aging. And over time, our abilities to think and to use higher cortical functions may be affected just by simply aging. However, at some point, that threshold becomes more into what we call a pathological state, in which patients start to have true sustained affections of certain domains. We can do that with some screening tools in the clinic, or we can do a formal psychological assessment, and that will give us some way to quantify these deficits in these various domains. And as I mentioned before, when the accumulation of these deficits lead to the loss of independence, that's when we start talking about dementia states. going more into the biology of what is happening in the brain of individuals with dementia, I want to introduce the audience to two proteins that perhaps you will hear throughout today's talk, and perhaps you've seen that in the news. One is the so-called amyloid, and the other one is a tau protein. So when I was a medical student and then a resident, I remember listening to these smart neurologists and thinking, oh, I want to be like them one day. And I still think the same way. I want to be like them one day, because they seriously have an opinion that is strongly based on science. And they say, no, Alzheimer's is due to amyloid. And then you have this other group of really smart people that says, no, Alzheimer's is tau. And you have almost like two groups of individuals that they have valid reasons to believe from a scientific standpoint that one or the other one might drive the disease. And what we've been learning in the last decade or so is that perhaps both groups are right. And we know that these two proteins accumulates in people's brains with Alzheimer's. We also know that individuals without Alzheimer's may have amyloid. So the presence of amyloid does not necessarily mean that someone is going to develop Alzheimer's. And just to make it a little bit more confusing, some individuals with Alzheimer's don't have amyloid. So it's something that we see a trend that these proteins are there. They have perhaps a function in causing the disease. But also what we are learning is that instead of seeing them independently from one another, we are starting to learn that actually they synergize, they work together in a way against our brain health. And latest research is showing us that actually both the amyloid deposit, which is extracellular, so these are the plaques that you see in this cartoon that are these brownish plaques that you can actually see in the brain, individuals with Alzheimer's, so you can see macroscopically. And these plaques actually accumulate in a temporal relationship that appears earlier in the process of the disease. And then you see this tau protein that gets hyperphosphorylated, almost gets activated and it accumulates inside the neurons, right? So one is outside the neurons, the other one is inside the neurons, right? Extracellular and intracellular. And rather than seeing them as independent proteins that perhaps coexist, we are starting to understand that they do influence each other. And this is an important principle because, as I mentioned before, the field of experts in Alzheimer's is pretty much divided. And that also led to treatments for Alzheimer's being also almost looking at the picture from one angle. So there is a group of drugs that were developed to target amyloid, and there is a group of drugs that was developed to target tau. And as we will learn in future minutes from Dr. Pressman, the results may or may not be convincing that they're beneficial. And what we are starting to understand is that, well, perhaps we are looking at the picture from only one angle, and we should start looking at a combination of therapies or affecting both proteins as opposed to just one. So there is a lot to be learned from this theory. Is something that we will hopefully learn more in future presentations, but it's something that I want to pose at least the question of, we don't know what causes Alzheimer's, but we do know that these pathological processes are happening and perhaps influencing one and another. As I mentioned before, there is a trend to see temporal relationships of when these proteins will accumulate, and we see that early on, amyloid tends to accumulate prior to identifying tau inside the neurons, and that could be anywhere between 10 to 20, sometimes 30 years prior to the onsets of cognitive decline. And we do see that through what is called biomarker studies. It could be anywhere from PET scan that are specialized type of imaging studies that are going to measure these proteins in the brain and give us a visualization of these proteins. But also you can, in a sense, peek into the presence of these proteins by doing spinal fluid analysis. And that's something that we can do in the clinic, and it's relatively easier to do than to approve a PET scan. And talking about PET scan, this is how it looks, and I like it because it's colorful, and we like colors. And you can see that here, in this case is amyloid. So anything that looks red and orange has higher concentration than anything that looks blue, and yellow and green are somewhere in between. And you can see that in a normal individual, which is the first pictures that you see on your left, there is little, if any, presence of amyloid, but there is some presence, as I mentioned before. Not everyone with amyloid will develop Alzheimer's, but then you see that in individuals with later stages of Alzheimer's, there is more of a widespread involvement of this amyloid. And there are wonderful theories looking at networks in the brain and how this amyloid will move from one place to the other one, and why people have this not only temporal, but actually regional accumulation of amyloid that are fascinating. So as I mentioned before, when you start looking at this amyloid PET imaging in individuals with so-called normal aging or with Alzheimer's, you can see that sometimes it's not that different. And that's why often we say, well, if individuals have the same amount of amyloid and yet one has clinical dementia and the other one does not, what is making that difference? Is that the presence of brain reserve, or being brains that are more resilient to sustain this pathological accumulation of proteins? We don't know yet, but we are getting there. But perhaps this also explains why clinical trial data that targets one protein only in a group of individuals may have varied results when it comes to the clinical outcomes. And just to finish my brief presentation now, one of the good news, if there is a good news in this topic, is the fact that the overall incidence of dementia appears to be falling in the last decade. And as you can see, the numbers, whether it's the overall numbers of dementia or the Alzheimer's or vascular dementia, appears to be lower. And caveat that we do know that these studies, for the most part, are very biased when it comes to what population they're looking at. And for the most part, these patients included in the studies are Caucasians and white individuals, or perhaps individuals that also have better access to healthcare and health nutrition and all the factors that we do know that may play a role into not only not preventing, but at least influencing the development of dementia. When you start looking at these same incidence numbers in, for example, Hispanics, Latinos, or African Americans, it is actually the opposite. Instead of declining, we see that there is an increase in the number and incidence of dementia. So please take these numbers with a grain of salt. Perhaps there is a selection bias when it comes to the population that has been studied. And as I mentioned before, and we did have a research lab that also Dr. Pressman and Dr. Flynn participated last February. So that's video is available for those who wants to learn more about it. We presented the Lancet publication that looked at those 14, I believe, factors that are known to influence the development of dementia or somehow prevent the development of dementia. Anywhere from early education, early on in life, to the presence of cardiovascular risk factors that negatively influence people or increase the risk of dementia, hearing loss, sleep, diet, physical activity, and so on and so forth. So with that, I'm going to bring it back to Dr. Flynn.
Thank you, Dr. Miravalle. We do have, again, the opportunity to type questions in through the Q&A box. And as is always the case, a very popular question is, this is a lot of stuff on these slides in a short period of time, so can I access these talks later? And the answer is yes. So I put a link up. I'll put it within the chat a few different times as we go throughout, and I've also put it in the Q&A box for where you'll be able to find this presentation posted. Maybe by the end of the week. I'm not sure how quickly we'll have it up there, but in the near future, you'll be able to access this and take a little bit of extra time on particular slides if there are any that you want to go over again on your own. You know, Dr. Miravalle, another question that came up that we were wondering about is, as you're demonstrating these potential declining numbers in dementia in recent years from the Framingham study from Framingham, Massachusetts, and you point out some possible ethnicity differences that may feed into that. And then on the next slide, you also brought up some maybe lifestyle and environmental or lifestyle choices that can impact dementia. Are there anything in particular about maybe living in Massachusetts versus Colorado? Are there environmental factors that we should think about that may play into the development of dementia?
Absolutely, and that's a great question. So one of the things that we learned recently is that air pollution appears to play a role into the risk of developing dementia. So individuals that are exposed to higher levels of air pollution have also a higher risk of developing dementia. And even though I like to think that Colorado has clean air, whether it's due to fires in the West or who knows, but actually our air quality is not as good. So there are many things we can do. I mean, I hope that the use of masks not only may prevent some of the viral pandemic issues and disasters that we're living, but perhaps will help us breathe a little bit better. But certainly things like smoking, for example, or other environmental toxins that we may be exposed will certainly determine perhaps geographical variations that we see of the incidence of dementia beyond age, beyond education and race.
That's really interesting. Thank you. So maybe a nice actual side effect from COVID and the mask wearing. Well, I think trying to be mindful of time here, I'm going to jump on to Dr. Pressman's next section. What is the available clinical data for aducanumab in terms of clinical efficacy in AD? Dr. Pressman, if you want to take it away.
Sure. Thank you very much for the introduction as well. So let me begin by just kind of setting the stage a little bit more, just to help people understand kind of where we were prior to aducanumab. In addition to the lifestyle changes that we were just discussing, there were some medications that were FDA approved to treat Alzheimer's as a cause of dementia. These treatments were really symptomatic. They weren't intended to cure or reverse the disease and didn't address the plaques of amyloid or tangles of tau or even any inflammation. Rather, they just helped boost brain chemicals, neurotransmitters, to help the brain cope with the progressive illness that it was suffering from. We have currently about 5 medications that are FDA approved. Really only 4, or more realistically 2, are commonly prescribed, those being cholinesterase inhibitors such as Aricept or donepezil, and another called Namenda or memantine. And those were last approved quite some time ago, years and years. And so it was with excitement that we looked forward to a, quote, biological therapeutic, something that might actually target parts of the disease itself and slow down that process. Aducanumab had early promise in this. The early data looked really good. And as things have progressed, a lot of controversy has come with it. My goal is to try to introduce you to different angles and different perspectives on that controversy so that you can decide things for yourself as best able. This is meant to be a kind of journal club, and I'm reflecting the opinions that were published just on August 28th, I think, in the New England Journal of Medicine, reflecting some of these different perspectives. So before we dive into that, let's talk a little bit more about aducanumab itself. Aducanumab is meant to be an antibody against amyloid, and the data that it clears amyloid are very good. So it really looks like it does that, based mostly on PET data. However, it is not without side effects. 35 to 40% of cases end up having ARIA, or brain swelling, that we can see on MRI. That's usually asymptomatic. We don't usually have any symptoms that come along with that brain swelling, but it's hard to see signs of brain swelling on an MRI and just kind of say, oh, that's fine. The approval, as I alluded to earlier, was really based off of the ability to clear the amyloid, which seems clearing that amyloid is more debatable and feeds into kind of a back and forth controversy, which Dr. Miravalle has been talking about a while, that also goes back for years, between people who really said amyloid is the key, it's the answer, it's what we have to target, and others who might want to target tau or inflammation or other aspects of the disease, thinking that amyloid is not actually a good target. I think it's important to know that the study of aducanumab really focused on people who are greater than 50 years old in very early disease stages with a mini mental state exam, which is a test that we give people to get a sense of the disease severity greater than 24. And it's usually only at the point of 26 or less that we're concerned about dementia or even MCI, mild cognitive impairment. They excluded people with strokes. You had to be able to get an MRI, couldn't have a seizure history, significant cancer history, high blood pressure, heart disease, bleeding disorder, liver disease, HIV, have blood thinners. So these studies were really done on a pretty highly selected group of people. And it's hard to say, even within those, how well the drug works. Outside of that group, it's going to be very difficult. Let's go ahead and move to the next slide. Thank you for that. I'll try to keep it rapid. So this just reiterates some of those enrollment criteria, which now I've just rolled off some of those for you, are now being considered the best use of aducanumab if it's going to be used. I don't know any physicians who would recommend use outside of that population. For example, if a dementia had really progressed to severe stages, or if you were on blood thinners, if you had a serious stroke history, I think all of those would be disqualifying for use of aducanumab according to most physicians now. Let's go ahead and go to the next one. So I alluded to the fact that despite its early promise, there's been a lot of subsequent controversy, and I'm going to kind of reiterate that now. In 2016, articles were published in Nature which were really promising, especially for removing the amyloid. And that was very exciting and sparked two large, what they call phase 3 trials to find signs of clinical efficacy. Is this going to help removing the amyloid in this case? So you see a lot of patients were involved, over 3,000 patients with mild Alzheimer's dementia or mild cognitive impairment. Now, these studies were both designed with what was called a futility analysis, meaning that if it really looked like, based off of this interval analysis, it wasn't going to work, they would stop the study. The reason why companies do that is they don't want to expose people to a drug that has no chance of helping or a reasonably unlikely chance of helping, and it's expensive to run studies that are this big. And back in March of 2019, these studies were stopped based off of the futility analysis. So an early analysis suggested this isn't going anywhere. This doesn't look like it's going to work. And so the assumption at that time was that like the hundreds of clinical trials focusing on Alzheimer's before, these were not going to go further. But then people did another analysis, which suggested that in one of the studies, Emerge, at the highest dose in an even more select group of people, there may be some improvement on some outcomes or relative improvement. So a slowing of the decline compared to people who are on placebo. That sort of analysis, going back and looking at the data later, is sometimes regarded with a little bit of suspicion. It's allowable, but it's not considered as trustworthy as sticking with the original plan. So this begins to raise questions in people's mind, but it's still playing by rules. Based off of these later analyses, Biogen, the company that sponsors aducanumab, proceeded to the FDA. There was a very preliminary review, which sounded positive, and almost the next day, a panel of experts gave a very negative review to the data that were involved. Basically, if you looked at two trials, the expert panel argued, and one says no and the other says yes, you're kind of at an equal chance of whether or not the drug works or not. And that's even if we believe in these kind of later analyses as opposed to the earlier futility analysis. And so of that panel, there were 11 people, 10 people voted against approving the drug, and the last person abstained and just didn't share that opinion. However, that didn't stop the approval, because there was yet another route, another kind of administrative procedure through which the drug could go forward. This route is really focused on serious illnesses with limited treatment. I do think that we can agree that Alzheimer's would qualify as that. Where things get tricky, and they say, is with a reasonable expectation of benefit. So the FDA argued that because of the clearing of the amyloid, this should, based on our understanding, benefit people. And so they went ahead and approved the drug, despite the earlier expert panel's recommendations against. Initially, when it was approved, in fact, it was approved very widely for basically all forms of Alzheimer's, though the FDA later clarified and restricted its use to be more in line with the actual study conditions. Another bit of controversy, which I think most people outside of Biogen disagree with, was the price tag of about $56,000 a year. And I know Donnell Hubbard will talk about that. The Alzheimer's Association is also taking up arms against that price tag. In the face of this approval, there's been yet more controversy. And I'm just going to give you a sense of how heated it is with the following kind of bullet points. Of those panel members, all of whom are very esteemed in their profession, highly regarded, 3 actually resigned in protest. There is a petition being circled among many professionals, physicians, asking CMS, the approval system for Medicare, to not approve the drug. Many professional associations, like the American Neurological Association, the American Geriatric Society, has recommended against its use outside of clinical trials. And an important point, as part of the FDA approval, they said that Biogen had to take further steps to prove that it worked. So doing what they call a phase 4 study. They had to follow how people do on the drug in the real world to show that this drug is going to work. On the counterpoint, they gave them 9 years to do that, which is a very long time to do a clinical trial. There has been some allegation of improper contacts between Biogen and some representatives of the Food and Drug Administration. Don't really know much more than that. There are investigations, though, that are ongoing. Several major hospitals and systems have refused to keep the drug on formulary or to provide it. One point that I think is frustrating to all of us in the field is that the results have yet to be formally published in a scientific journal. So one of the things we really want is to be able to review the data and see how much stock we have in it. And the main way we're used to doing that is reading an article in a scientific journal. We've yet to do that. This is all coming out from the company at conferences or independent meetings and things like that. So it makes it harder for us to judge. And so this has all gotten to the point where it's kind of a hot button controversial issue. So before, in groups of behavioral neurologists, we used to joke that talking about believing if amyloid or tau was more like talking religion. You had the Taoists and the Baptists who would really get into it. And this heightened the stakes, because before it didn't really matter for treatment, but now there was real potential cause for heated discussion. So in the same way that we might get a little anxious discussing politics or religion at the dinner table, now I get a little wary bringing the subject up and going into it. We still are trying to figure out if insurers will approve this as well. Different insurance companies are trying to decide if they want to pay for this, and if so, how much. So that's a lot of information there. Let's keep going into it. So here's what we have of some data. This is a change in what they call CDR sum of boxes. It's a way of trying to get at whether or not people are having loss in independent daily function, one of the definitions of the dementia, as Dr. Miravalle alluded to earlier. Here we are looking at only the high dose group, the people who got the maximum dose, versus placebo. And what we see here is that both are changing from the baseline. Both groups do continue to get worse, but one group doesn't change quite as much as the other. The group on placebo seems, over the course of 78 weeks or so, to not, the placebo group changes more than the group on drug, according to these data that we have here. I think a more impressive graph is yet to come. Oh, let's look at some others. Sure. They did look at some other measurements as well. So there's the CDR sum of boxes, but they also looked at the mini mental state exam. They looked at the ADAS-Cog. They looked at a neuropsych inventory. And the thing to notice is that all of these do show significant differences between those on and those off the drug compared to placebo. So that P equals, that stands for a p-value. The tradition in science and most medical science is a p-value less than 0.05 is considered statistically significant. I emphasize statistically here because even while something may differ, it doesn't say that it differs very much. And so we can say that this differs, but is it a meaningful difference? Is it worth $56,000 a year worth of difference? That's another point of controversy. Let's go ahead and go to the next one. So they also looked at PET scans of people who did and didn't get aducanumab. And as I mentioned before, the amyloid data is pretty compelling. We can see that there is less amyloid in those who got the drug versus those who were on placebo. Let's go ahead into the next one. And this shows that in graph form. The little error bars around the end give you a sense of the size of the difference. These are much further apart than the first graph that I showed you that was like this. So while we may find people who disagree on the significance, either statistical or clinical significance of the improvement to cognition in daily life, I think everybody agrees it does clear the amyloid. Let's go ahead to the next one.
All right, I'm going to jump in quickly, if you don't mind, Dr. Pressman, and thank you for taking us through the current evidence that we have out there that lets us know how or how not efficacious this medication may be. And it's clearly it's a bit of a mixed bag, it seems. We do have a few folks who have typed in some questions. I think in the interest of time, we're going to respond to those within the Q&A boxes themselves, and we'll type you answers back. And so Dr. Pressman or Dr. Miravalle or Danelle as well, anytime you have a few free minutes, if you wouldn't mind, just perusing those and providing any feedback you may have would be really helpful. I think now we're going to jump back to Dr. Miravalle and have him tell us how is aducanumab administered, and then what are the safety concerns that may go along with that as well?
Yeah, thank you, Brett. So aducanumab is an intravenous infusion, so it's administered IV. And for that reason, patients will have to go to an infusion center, and that's they will have to be monitored. The infusion is relatively short. It's approximately 1 hour to complete, and that the interval is every 21 days, or at least every 4 weeks. Every 4 weeks will be the ideal, but at least 21 days in between the infusions. And as Dr. Pressman mentioned, there is a dose effect, but also that dose effect not only relates to the efficacy, but also the safety. And for that reason, the medication has to be gradually introduced. And that's why you see that the first 2 infusions are a tiny dose, 1 milligram per kilo, and then it takes up to 7 infusions to reach that maximum dose of 10 milligrams per kilo, which is the only one that showed, if any, some benefits. So as Dr. Pressman mentioned, there is perhaps the most concerning side effect is something we call amyloid-related imaging abnormalities with an acronym of ARIA. And there are two different types of ARIA, something that we call the ARIA-E or the ARIA-H. So the ARIA-E stands for edema or swelling in the brain, and the ARIA-H stands for a hemorrhage. And it just, if we pause for a minute and explain how this drug works. So the drug itself, it is an antibody. And that antibody is going to travel through the blood, reach the brain, and try to bind to that amyloid that is aggregated into those plaques. And after binding to that, it's going to try to clean that and remove the amyloid from the brain. And as Dr. Pressman mentioned, when you look at the PET scan data, it looks pretty promising. It does clean up substantially the amount of amyloid in the brain. However, in that process, like anytime you clean something, you could create some secondary damage. And what could happen is that in some individuals, it could be up to 35% of those individuals. In the process of cleaning that amyloid from the brain, you could create some damage into the microvasculature, those small vessels in the brain. That damage could lead anywhere from swelling, in the case of edema, all the way to small little hemorrhages or bleeding. And that's known as ARIA, or amyloid-related image abnormalities, that, as I mentioned before, could be as high as 35%. So these are pictures of how that look like on an MRI, and you can see on the picture A that's what the swelling looks like in those white-looking lesions in the brain on the right side. You can see in C and D that those could happen spontaneously too. So they look different when we see that in patients that had the medication versus spontaneous edema or swelling. And radiologists have a way to quantify that abnormality anywhere from mild, moderate to severe. And what we've seen in the clinical trials is that most patients with mild and moderate, they don't have symptoms from it. So it's something that we will have to monitor proactively in anyone that receives this medication with an MRI every 4 months to make sure that we capture these abnormalities as early as possible so we can stop the medication and provide proper guidance and treatment. Most of the time, these abnormalities will resolve, and you can see here, if you go all the way to the bottom, it will not cover all the top because of time, but if you go to the bottom, you can see that individuals that develop ARIA, and you can see the swelling in the back of the brain after they stop the medication and they receive steroids, that significantly improved, and not only improved radiologically, but also the symptoms that patients in that case had also improved. So it's something that we worry about. It's something we have to be proactive, and patients have to be informed about this risk. For the most part, it's something that we've seen that could be managed. However, again, nobody wants to induce in your patient swelling or bleeding in the brain if there is not a good understanding of the benefits.
Thank you, Dr. Miravalle. So this, really, I think, starts to get to the heart of the issue that we've been asking and kind of dancing around throughout the past 30 or 40 minutes. We see that people seem to respond differently. There are some individuals who tend to have some relatively severe side effects. So, Dr. Pressman, when we get down to it, who is theoretically or potentially the ideal candidate for this type of medication? And we've already heard a little bit as to why, but what really underlies the controversy surrounding this? Dr. Pressman, you're on mute. Sorry about that.
Oh, that's my turn to apologize. I think that it's fair to say that despite the controversy, we are at a new point. We're still trying to make sense of exactly where we are. But a threshold has been crossed. This is the first time that the FDA has approved a new medication for a long time, particularly one that is targeting the putative cause of Alzheimer's, or one of the many possible causes. Many providers, medical providers, and many patients still seem interested in this. though we're still awaiting a lot of details on this phase 4 clinical trial, and we're still waiting to hear from most insurers about whether or not they're going to pay for it and not make people pay out of pocket. So we're still trying to figure out how to best use the medication. There are some guidelines that are coming out, which for the most part recommend, if it's going to be prescribed at all, to do so while adhering very closely to the original design of the studies. There's also things like questions about genetic testing. So the studies suggested that the drug is most effective in people who are positive for a gene called ApoE4. Unfortunately, the same studies also suggest that risk of side effects, such as bleeding in the brain, is also highest in the same group. So do we bother testing for that? And what will we do if we find that the gene is positive? Most of the people that I know who do test for the gene do so as a way to exclude people from the drug, because they know they're confident about the risk, but less confident about the certainty of the benefit. There's lots of reasons why why many people support the drug. There were some positive findings in one trial, although that was on post hoc analyses, as I mentioned, a subsequent analysis. There seems to be a dose-dependent relationship, though even that seems occasionally nebulous. There are arguments, again, from the people who really support amyloid as a cause and that say, no, there's more and more evidence that amyloid is the cause. I know at least as many people who would say there's more and more evidence that amyloid is not the cause and we should really focus elsewhere. The FDA pipeline through which this was approved, they would argue then, is technically correct. So the FDA has a pipeline for drugs where there's no other treatment and there's a real need if there's an expected benefit. The argument against that is those who don't think treating amyloid is the best approach would say, well, we don't actually expect there to be much of a benefit. There's an argument of trying to let the perfect be the enemy of the good. The FDA often wants to have 2 major trials, but where there's so much need, should we really hold ourselves to such a high standard? Others would say, yes, we should. There's, I think, an argument for this being an important first step for encouraging others to get into the field of Alzheimer's therapeutics. Can we try to get more people excited about trying to find cures? Many people were steering away from Alzheimer's for a long time because of the track record of lack of success. The problem was just thought to be too hard. However, we're not confident that it will actually do this. And even if it did, is that why we approve a drug? Is in hopes that a better drug will come along? Now some arguments, kind of con. Let's go to the next slide there. I've covered some of the irregularities in the approval process, which are still under investigation. I've mentioned the concerns about the risks versus the benefit. There's a fair amount of brain swelling there. There's also other side effects that, such as headache and others. This lack of peer review, if this is such a compelling drug, well, why don't you publish the data and let all the medical scientists look it over and review it? And there's that concern for statistical significance. So even if we've shown that there is a difference and we buy that, is that difference really big enough to justify the cost, to justify the side effects? There is a concern as well about what this means for the medical system. Alzheimer's is rampant. It's very, very common. And it leads to a lot of people who really want a cure. If a lot of these folks were, or if the government or other insurers suddenly had to pay $56,000 a year for all of these people, that's a very large expense. can we justify that for the same kind of risk-benefit ratio that we've been discussing? And then there's this question of, okay, so why did the FDA suddenly switch and say that amyloid was a good endpoint? They had never really given much indication of that before. It's kind of a new thing that just came up when this drug looked like it was getting into trouble. So, and there are many who argue against the validity of that endpoint, that amyloid is not probably the best trial. One argument that came from one of the FDA board members was that this overwhelming unmet need in this common and devastating disease should drive research investments, yes, but not lowering of regulatory standards that we rely on for safe and effective medicines. It's a little harsh. I don't know if they lowered their standard per se, but the spirit of the argument is still true. There seems to be some reason for questioning this process and how this drug came forward. I would also argue that not only should we be focusing on more research investments, maybe we should be focusing more on caring for people who have dementia now and providing better living conditions, resources, and maybe we should be focusing on prevention based off the data that we talked about and showed earlier for lifestyle adjustments. So let's go ahead and move on. Either way, we are in this kind of new phase. And so the question is, how will we screen for people and make sure that those who need it and who are eligible can get this drug and that it's not being given inappropriately? So we've given some thought for screening, starting with age and concern for cognition, then moving on and getting a test to see if we can measure that cognition, both to make sure that there's some dysfunction present, but not so severe that they would fall outside of the range of most likely to be helped by a drug like Aducanumab. If it's positive, we still can't forget the other things that we routinely check in someone with dementia. We don't just jump and say, okay, there's a problem, here's some aducanumab. We have to check you for things like depression. We have to check your thyroid. We need to check and make sure you don't have vitamin deficiencies. We need to make sure that your sleep is good. So we need to not forget the big picture and just focus on one drug, particularly a drug steeped in so much controversy. However, if there's no improvement after addressing those other things, or if all those screens turn up normal, then we would move forward with a dedicated consult for further evaluation. Most people would insist on biomarkers. So one of the strengths of the aducanumab trials was that we actually assessed and saw if Alzheimer's proteins were present. And only those people were allowed in the trial. Previous trials, that wasn't so, and it turns out that misdiagnosis of Alzheimer's is not uncommon. And so a lot of the people who were in earlier trials may not have actually had Alzheimer's disease pathology. If, however, we get those biomarkers, most likely through a lumbar puncture right now, although there's more push for PET scans to be approved and more development for a blood test. If those do show the drug, then we could put people into a rapid protocol to administer it. I do have to say that after weighing the pros and cons and having these conversations with patients, very few have moved forward. I think the price tag limits a lot. We'll see what happens if insurers start covering this more. Another thing which I'll mention is it doesn't stop there, but we need to go on with monitoring. So once you get that infusion, as Dr. Miravalle was saying, this is a monthly process, and we need to keep on screening people for signs of brain swelling and so on. So this would require regular MRIs, just an added expense both of time and money. So Go ahead.
If you don't mind, Dr. Pressman, I'll just say this is a lot of great information. Hopefully folks won't mind sticking with us. We have a few more components to cover. If you don't mind staying with us for a few extra minutes, I think we'd like to just hit a couple of more ideas, and then maybe most importantly coming up right here with, so what's next? What are other potential candidate drugs that we might consider, Dr. Pressman? What's in the pipeline?
Sure. So one thing that I will say is that the approval of Aducanumab has encouraged others to bring forward similar agents. So Eli Lilly and Eisai both have drugs that also clear out amyloid. And now they're saying, okay, you approved this drug based off clearing amyloid. That gives us hope. And so they're really moving that forward. I do think that that's likely to be approved. Hopefully that lowers prices further. There are more drugs going through the clinical process pipeline. A lot of them are anti-amyloid still. I can't say I'm very enthusiastic personally about that approach, given the questionable and even if present limited success of aducanumab. But we're also looking at things that focus on tau. We're looking at inflammatory markers and just symptomatic benefits still. Can we treat agitation, apathy, sleep changes, and more? Now, we were going to talk a little bit about other forms of dementia, but we might have known that aducanumab was going to take a while.
Yeah, maybe we'll touch on them briefly. As Dr. Miravalle primed us for earlier, there are certainly different kinds, such as vascular dementia, mixed dementia, et cetera. So maybe we could just talk about frontotemporal for a moment, if you don't mind.
Not at all, though FTD is a focus of mine. It's sometimes hard to be brief. Suffice it to say that FTD is a group of dementias that impact, rather than memory, as is classic for Alzheimer's, different aspects of language and behavior. So personality changes may be very prominent in the behavioral variant, and sometimes people will selectively lose their ability to come up with words or to speak, so they'll get an aphasia. In this case, this is not likely just run-of-the-mill Alzheimer's. You should certainly not be a candidate for something like aducanumab. It is less common by a lot than Alzheimer's disease, but can be especially devastating when it does come. It is also frequently genetic, but actually the majority of the time, just one of those things that happens. We do have a study of that ongoing at the university, as well as other studies, clinical trials, and so on, both helping us understand Alzheimer's and looking for other ways of treating or curing the disease.
Thank you very much, Dr. Pressman. We also have our special guest, Danelle, is with us, and we spent a fair bit of time, obviously, touching on medication and how we can use that. And Danelle has, within the chat for all of you, has posted a 24/7 helpline, as well as her website. And we're hoping maybe you could just give us a brief overview, Danelle, of, besides medication, what can patients and or caregivers do?
Yes, and thank you so much for inviting me and for, I would say, a very fair conversation. And this is a conversation we welcome at the Alzheimer's Association related to this new treatment. I will make one little point about it, is that we see the science and the research of Aduhelm as a different topic than the cost. We've come out publicly and made the statement that that's an outrageous cost. Our focus is giving access to those who can benefit potentially from this treatment and treatments like it. So that is kind of my little 5 cents on that. But yes, we have our premier support for families in the community is our 24/7 helpline, 1-800-272-3900. You will have access to a master's level clinician like myself, who can answer questions, including about Aduhelm, including questions about if you have concerns that you're experiencing cognitive changes or a loved one is experiencing cognitive changes. And that is at no cost to the community. So we welcome anyone to call our helpline, and we're available in over 200 languages. in providing this service. We also have a wonderful, wonderful website at alz.org where you could actually do a tour of the brain. So many of the images you saw presented today are also there, and you can actually interact with those images and learn more. And I remember seeing the, I put a specific link on the heredity question because we had resources specific to that, and along with the other resources on behaviors, communications, and what families can do to engage, because treatment it's wonderful. We're excited about it, but we still have people here today who are living with dementia and their caregivers. And so we never lose sight of that. And so we have online classes, we have support groups. One of the things I'm proudest of is that we were able to pivot from our in-person to virtual, including a webinar specific to COVID-19 and Alzheimer's disease and the special challenges of care in this current environment. So we welcome you to engage with us and chat with us about any questions, concerns, or any resources that we can help. We are grateful, so grateful for our community partners and being able to bring resources and support to you through them as well. And that is it for me. I know we're short on time.
Danelle, thank you so much. I want to just make a quick comment that Lene said your caregiver source book was extremely helpful to my family, and she just wanted to give you a special shout out and say thank you, Danelle.
Well, thank you. Thank you for sharing that.
Yeah, we've also placed, I also put into the chat for everyone to see as well that genetics link that you provided as well within the specific Q&A. So if anyone's looking for that, they can find it there as well. We, of course, would be remiss if we did not thank our sponsors as well. So they're helping drive the science and the research and the medication. Biogen and Alector are also kind enough to help support conversations like this with physicians, community support, and potential patients and the community as well. So we thank them for their support and allowing us to be able to put on these community-based lectures and engage folks and try and work our way through what is clearly a very complicated issue and role out there.
And thank you, Fran. I see that you put the Alzheimer's Walk is at City Park in Denver. So we're in person this year. So thank you for that reminder. It is this Saturday. So we're following all the COVID guidelines, but thank you for sharing that as well.
Should be a beautiful day to get out there in a city park and walk around a little bit for a good cause. Perfect timing. And Dr. Miravalle, if we have anything else to add?
No, I just want to say thank you, Peter Pressman, Dr. Pressman, for being another wonderful addition to the panel today, Dr. Brett Flynn and Danielle Hubbard for your participation. On behalf of the Brain Health Center of the Rockies, I also want to thank the sponsors, Biogen and Alector, and also the audience for following us and for attending this talk. For those who wants to listen again or would share this, it is going to be published in our website. That could be found at www.brainhealthcr.org, and hopefully soon. So I need to understand how to transfer this into a file, and that could take anywhere from a minute to 2 days. So be patient. It's going to be there. So with that, thank you again, and hope to see you soon.
Thanks, everybody.